Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. Today, I'd like to address an important topic of luteinized unruptured follicle syndrome and to highlight new insights in its management. You know that the WHO grouping of ovulatory disorders was based on hormonal assay of the patients. And recently, the FIGO designed another classification of ovulatory disorders based on anatomic origin with PCO. And this classification is called HypoP, which is hypothalamic pituitary ovarian and polycystic ovarian disease. And each sector has been divided into further subgroups, and the new in this thing in this classification is to put PCOS as a separate group. But we have to know that this classification mentioned that luteinized unruptured follicle should be considered as a cause or type of ovulatory disorders. So what's luteinized unruptured follicle syndrome? Actually, it is a physical failure of dominant follicle rupture, which is oocyte release, after LH surge. So the patient has LH surge. If you measure LH for this patient, she has LH surge, but the follicle does not rupture, and the follicle is retained or entrapped inside ovary with luteinization and other endocrinal features of the secretory phase of the menstrual cycle. This is the definition, but actually it is difficult to diagnose luteinized unruptured follicle. Some authors mentioned it is trapped egg syndrome, and it is one of the causes of disturbed ovulation or anovulatory disorders, as I told you. And some authors mentioned that it is a transient cycle phenomenon. The instance of LUF is previously mentioned as a rare event in the early research, but with the common use of induction ovulation, with the frequent use of transvaginal ultrasonography, the instance is rising, and particularly in patients with infertility, of course, and with irregular cycles, and patients with unexplained infertility. But we have to know that this event, which is LUF, is not persistent in every cycle for the same patient, can occur intermittently with normal ovulation. It has been recently mentioned that the incidence is around 10% in natural menstrual cycles in the females. It's high with induction ovulation. It is very high in infertile women, reaching up to 43% of cases. And recurrence rate is 2 to 3 times in the consecutive cycles. In 2 to 3 consecutive cycles has been reported to be around 79% and 90% respectively. So we have to give some attention to this LUF in our practice. What's the etiology? Etiology may be hormonal imbalance, which is defect in the LH surge, abnormal FSH, or hyperprolactinemia. May be mechanical due to firmly adhesions adherent to the ovary, making entrapping of the ovary, or due to chronic inflammatory process. And if we go back to the basic knowledge of how the normal follicle ruptures from the ovary, we have to know that there is increased vascular endothelial growth factor that leads to increased blood flow and vascular permeability, in addition to increased matrix metalloproteinase and increased proteolytic enzyme activities in the follicular wall, All these things will lead to hyperemia and tissue remodeling, which leads to an inflammatory process. How to know that it is an inflammatory process? This can be known easily if you take a sample from the follicular fluid or fluid in the pouch of Douglas. You will see a high percentage or high concentration of the cytokines in this fluid. These cytokines are markers of inflammatory process. And this is the basic of many lines of treatment in the publications on the Luteinized Unruptured Follicle syndrome. One of the important cytokines is granulocyte colony stimulating factor, which has been used as a marker, and also the treatment of this increased cytokine is published in many publications. So these concentrations in the fluid of the follicle and in Douglas pouch highlights the central role of leukocytes or granulocytes in ovulation. And this is a figure of how ovulation occurs by increased follicular fluid, increased vascular permeability, increased cytokines, and all these lead to follicular wall degeneration and subsequent rupture. So the patient with unruptured follicle has defective either hormonal or anatomic, which are adhesions, or a defective inflammatory process of ovulation. Who is liable to have luteinized unruptured follicle syndrome? Those patients with infertility, particularly unexplained infertility, polycystic ovarian disease, endometriosis, patients with history of laparotomy and pelvic adhesions, patients receiving some treatment like non-steroidal anti-inflammatory drugs or clomiphene citrate, patients with hormonal imbalance, like hyperprolactinemia, abnormal FSH, or defective LH surge, or patients subjected to intrauterine insemination. These are the high-risk factors for developing luteinized unruptured follicle. If we go in short in these risk factors, we will see that clomiphene citrate is associated with or results in ovulation rate in up to 80%, but pregnancy rate is as low as 40% due to many deleterious effects of the clomiphene citrate on the endometrium, on the cervical mucus, but also in 35% of cases, there is luteinized unruptured follicle, as mentioned in some studies. That's why a recent randomized control trial found that letrozole is better than clomiphene citrate in treating patients with polycystic ovary, and this was based on 29 randomized control study analysis. Patients with polycystic ovary, there is a high instance of LUF in consecutive cycles with clomiphene citrate in unexplained and polycystic ovarian patients compared to clomiphene citrate and HMG or HMG alone. And the cause of a high percentage of LUF in PCOS may be due to hormonal imbalance associated with PCOS, maybe thick capsule that hinders the rupture of the follicle, maybe decreased or abnormal some cytokine activity in the follicular fluid. And we constructed a study on the patients of PCOS before, and we found that there was abnormality of the insulin growth factor 1, which may contribute to a disturbed follicular development in PCOS. And this has been published in the Fertility Journal. Regarding endometriosis, there are some problems with patients with endometriosis that may facilitate occurrence of LUF, which include decreased receptors for the LH and chorionic gonadotrophin, And this leads to decreased CMB and decreased COX-2, which is cyclooxygenase expression in the nucleus. And this leads to luteinized unruptured follicle, as mentioned in some animal studies. Patients subjected to intrauterine insemination are liable to have LUF, particularly those are receiving clomiphene as I told you before. Patients using non-steroidal anti-inflammatory drugs, this leads to decreased prostaglandins, and prostaglandins are very important, are essential in the process of rupture of the follicle. And many studies found that increased incidence of LUF syndrome in patients receiving non-steroidal for some rheumatic or arthritis indications. So these are the risk factors to develop LUFS. And what are the effects of the LUFS? It leads to no pregnancy, no follicle, no pregnancy. This is the first effect. But the menstrual cycle is not trapped. The patient will have normal menses because he has already luteinization. But we have to know that the mid-luteal progesterone level is decreased in those cases significantly, with decreased luteal phase duration in up to 2/3 of those cases. And LUF might negatively affect embryo implantation on ongoing pregnancy in natural cycle frozen embryo transfer. So the LUF may affect the second half of the cycle, which is luteal phase, and this is defective. This defective luteal function is important in cases of embryo transfer of frozen embryos. As I told you, 2/3 of the LUF patients have luteal phase defect. So these are the effects. And what about the diagnosis? The diagnosis actually is difficult because we don't do serial ultrasounds for all patients who are coming to our clinics. So it is a silent problem. Only diagnosed by serial ultrasound after the ovulatory phase of the menstrual cycle. And at that time, you will see lack of follicular rupture and lack of free fluid in the pouch of Douglas at the time of ovulation. But the patient will have normal menstrual cycle, will have positive LH surge because unrupture occurs after LH surge, will have biphasic basal body temperature charge, will have secretory endometrium in the endometrial biopsy, positive cervical mucus test, and will have sometimes high progesterone level in some cases and not so high in other cases, as I already mentioned on the endometrium. So these events will occur in the patient with LUFS, but we have to know that the only diagnostic method is serial ultrasound follow-up of the patient. If you do ultrasound, you will find the normal follicle continued to grow in size after the LH surge with thick wall, increased internal resonance, extensive intrafollicular bright spots that may be detected after 2 to 3 or to 4 days. This is first step. Second step is progressive enlargement of the size of this follicle, unruptured follicle, of 30 to 35 millimeter in diameter with strong internal resonance and persistent till the next cycle or even longer. And last point is to know that this event of persistence of the follicle is continuous on transvaginal sonography on different days after LH surge. And this echoes inside the entrapped follicle, maybe diffuse or linear, reticular or band-like, maybe low, medium, or high in the appearance by ultrasound regarding echogenicity. Maybe echoless, not always present. So these are variations of the sonographic appearance of the LUFS on serial examination. And they are important to be differentiated because the normal follicle is well known for all of us, pre-ovulatory. And after ovulation, we will see the corpus luteum. And corpus luteum has irregular wall due to rupture of the follicle as fluid in the pouch of Douglas. And this is very important to differentiate it from the LUF on ultrasound. Some authors classified follicles into LUF into small type or follicle retention type or follicle continuous enlarging type according to the size of the LUF on serial ultrasound. So the only diagnostic way for LUF is ultrasonography, but ultrasonography to be done serially for all infertile women coming to the clinics is very difficult because of many financial problems for the patient to pay for frequent ultrasound visits and to come to the hospital and to leave her work. Also time consuming of the doctor and of the patient as well. In addition to some psychological stress to monitor just one cycle for this lady by frequent ultrasound visits. And if you apply this approach for all ladies, this means that the clinics will be overcrowded by ladies, which is impossible in practice. Also, LUF may not occur every cycle. So if you follow up the follicle in one cycle, this does not guarantee that the unruptured follicle will not occur in the subsequent cycles. Also, you may have some diagnostic fallacies if the sonographer is in a hurry or with poor experience. He may diagnose it as corpus luteum or as LUF wrongly. So we are in need of a simpler method of diagnosis to be applicable for all cases, to be a fast, easy, simple, and less time consuming than serial ultrasound follow-up. How to manage? The manage is to predict LUFS in your practice. Not all cases are liable to have LUFS, but those high risk, as I already mentioned to you, who are using clomiphene non-steroidal anti-inflammatory, PCOS, the endometriosis, patients with history of laparotomy with pelvic adhesions, patients for IUI, those are importantly to be put in mind as high risk for developing LUFS, particularly if you tried a natural cycle or induced cycle for those cases before and they did not get pregnant. So you have to think of LUFS as a cause of failure of pregnancy. So prediction is very important. You have to put it in your mind. But now we have two types of management. If we have a patient diagnosed to be LUFS, the patient is usually depressed because he is under the stress of treatment and timing of intercourse or preparation for IUI or whatever. So you will say to her that the follicle did not rupture and you will not be pregnant this cycle. This carries a psychological problem to the patient and trauma actually. So the current management of the current LUF, how to do in such a case? You have to start health education by proper explanation of the LUF problem and answer all queries of the couple with psychological support, of course, assurance that this may not recur again in the subsequent cycle. At least this will alleviate the stress of the couple. And we have to search for a possible cause like hormonal imbalance, adhesions, PCOS, endometriosis. and follow-up ultrasound during subsequent menses. If the LUF cyst is persistent, we have to start hormonal treatment to make it shrinking. And if disappeared, it's better to stop induction ovulation at least one cycle to alleviate stress and to make natural hormones starting to become normal. And a break is good for such a case. And if we start induction ovulation, it's better to avoid colon citrate in the subsequent cycle. This is how to treat a current case of LUF, but prevention of recurrent LUFs in subsequent cycles is another line of management. This can be achieved by helping body rebalance, acupuncture, avoid non-steroidal anti-inflammatory drugs, selection of another type of induction ovulation, incremental increased dose of HCG, prostaglandins, GCSF, rule of laparoscopic adhesolysis, proper management of endometriosis and PCOS, and lastly, IVF-XC is the ultimate treatment. We already discussed health education and psychological support to avoid the drugs, avoid stress, avoid the factors that may contribute to development of LUFS. Helping body rebalance by giving her some vitamins, some herbal drugs to enhance ovulation and rupture of the follicle, and to support healthy inflammatory response of the ovary, and many publications on herbal and Chinese herbs for such a case, self-fertility massage, or systemic enzymatic therapy. All this has been suggested by some studies, but actually they are weak studies. Acupuncture also has been suggested as a treatment of LUFS based on a meta-analysis of 715 participants, but actually the level of evidence in such a case was low or very low. Non-steroidal anti-inflammatory drugs users should be instructed to avoid these drugs around the ovulation or altogether. Natural pain management are better than non-steroidal, like massage, acupunctures, and others. If we give induction for those cases, we have to take a break or switch from clomiphene to letrozole or HMG, and evidence in favor that letrozole compared to clomiphene citrate in terms of lower incidence of LUFS and induction ovulation in IUI cycles has been postulated. Some studies suggested incremental increased dose of HCG in the subsequent cycles after occurrence of LUF. Usually we give 5,000 or sometimes 10,000, but you can increase up to 20,000 units since LH is responsible for induction of follicular rupture. But if still according to these recommendations, after 20,000 units, IVF-XC is the best solution. We can use prostaglandins because antiprostaglandins inhibit rupture, so we can give prostaglandins, but these are animal studies using prostaglandin E2 or F2 alpha to overcome the process of LUFS, but not actually, there is no human studies on the use of prostaglandins. And there are many studies on the granulocyte colony stimulating factor as a cytokine, which is important for according to the inflammatory theory of rupturing of the follicle or ovulation. So a study here is a study compared patients with induction with or without GCSF subcutaneously 100 milligram at the time of ovulation between day 12 and 14, and found that it was useful for infertile women diagnosed with LUFS caused by ovulation induction. And here is the timing of G-CSF giving between day 12 and 14 at 13. And this drug has been used since a long time by the oncologists for prevention of febrile neutropenia for more than 30 years with high safety profile. So it is encouraging to be used and they considered it a breakthrough in the management of LUF, actually, or a new insight for such a case. And it is considered also as a target therapy. And finally, if the patient has persistent LUF or recurrent LUF or frequent LUF, so we can discuss with her the ART, which is IVF-ICSI, as a simple way to overcome unrupture because we aspirate the follicle mechanically, so no need to be under tension or under stress. These are the different lines of management. You will see that we can put prevention, prediction, prevention, and current treatment of current case. We don't have to ignore the role of laparoscopy in adhesolysis of firm adhesions that are adherent to the ovary, making entrapping of the follicle and avoiding rupture, particularly patients with history of previous pelvic surgery. And some studies recommended adding hyaluronic acid gel after adhesolysis or after ovarian surgery or ovarian suspension for prevention of adhesions. But ovarian suspension makes the ovaries away from the Douglas pouch and may make them difficult if the patient is subjected to IVF or ICSI, because egg retrieval will be difficult and dangerous at the same time because they are very near to the blood vessels of the pelvis. So in conclusion, we would say that LUFS is not uncommon syndrome, particularly with use of induction ovulation nowadays and frequent use of ultrasound. It should be predicted in high-risk cases. Serial ultrasound is the best non-invasive diagnostic tool, but it is not ideal. We should search for an ideal method for diagnosing LUFS in our practice. Health education and psychological support are essential basic measures. Modification of induction protocols will overcome most cases. And lastly, IVF-ICSI is the ultimate treatment of such a case. Thank you very much. If you have questions, you can send me on this email address.